when we're talking about teaching and learning, I taught Spot how to whistle. Silence. And then the accusation, I can't hear him whistling. I can't hear him whistling. And the reply, I said I taught him, I didn't say he learned it. And I think of all of this, of trends of teaching and learning, what we have to remember that the real customers, the real thing that matters is our students and what we as teachers can do to facilitate their learning. Thank you. It's wonderful to have an opportunity to return to Sudan and reacquaint myself with so many old friends who have done so much for education in this area, and to make new friends as well, as one always does at these sorts of conferences. So thank you very much indeed for the opportunity to come and speak. We've been talking a great deal about teaching this morning and about learning. And I think everybody would agree that it's axiomatic that essential features of a teacher are that they help student learning. But I'm going to take a slightly different tack this morning, because what I'd like to do is to discuss with you ways in which we can support teaching by strengthening our own activities in the area of teaching and teaching development. So this is more about us, perhaps, than about the learners in an immediate sense, although, of course, the ultimate objective of the whole thing is to help the learner, and perhaps the ultimate objective, if we were to trace it to its logical conclusion, is actually towards better patient care. Now, in any conference presentation, you need to know a little bit about the speaker. And so I just want to comment a little bit on what Alberta is like, because I bring, obviously, a perspective which is biased by the extraordinary length of time I've been in Alberta. People sometimes ask me when I joined Alberta, and I usually tell them it was shortly after the dinosaurs became extinct. Alberta itself is the most northerly medical school in North America. There is presently no school in Alaska. We're not actually that far north. There are plenty of schools in Europe that are a lot further north than us. But if you look at a map, you see we're fairly well up there. And in addition to being to the north, I suspect we certainly have the coldest medical school on the continent. I come from a very research-intensive university. And one of the things which is interesting is that very often this is seen as being the ideal. And when I travel in countries like Sudan, I hear about the urgent necessity for academic success to be focused on one's research activities. And while there's nothing wrong with that, I don't want you to think that the North American model, or even the European model, is the one which will necessarily lead to the best health for the community. I actually believe that we don't spend enough time thinking about the educational activities. And certainly in my university for many years, we spent far too much time talking about research. Our undergraduate curriculum in Alberta is 4 years, but graduate entry, which means basically it's 8 years, most of which are wasted. There are 2 preclinical years in the medical curriculum and 2 clinical years. And the preclinical years are in 9 system-based blocks. We use a hybrid teaching method. We have problem-based learning, we have lectures, and we have various other things. And the basic scientists are taught, and I personally like this, being a basic scientist, but they are taught in the context of the clinical cases. And I personally have a feeling that over the next few years, we're going to be placing an increasing emphasis on this because our students have consistently identified some areas in the basic sciences where they feel that they are deficient. Now, the next question is what happens after that. We have classical rotating clerkships, rotating internships in a variety of different areas. And the question, I suppose, is, does all of this work? And as Dr. Harden pointed out, what one means by excellence depends entirely on your own perspective on it. But at least we do reasonably well from the perspective of the licensing exams and the students. I should add that the student survey, which showed that 96% of our students were satisfied or very satisfied, was both anonymous and not conducted by the dean. So what's my role in all of this? Actually, not a lot. I'm a pharmacologist, so I don't do much in the way of clinical teaching. I have the fervent belief that our clinical teaching is the foundation of effective clinical practice, and I'm not in any sense knocking the basic science component. But given that we have great students, I made the point at one time, and I don't really believe it, that we could actually replace the faculty at Alberta with Irish setters, and the students would still do very well on their final examination. But my office, however, so I did have a little bit of a role in this, directed the whole issue of curriculum reform. And we do a lot of other things. And what such offices of medical education do to support the educational mission of our training centers for physicians is what I'm going to talk about. And because I spend so much time talking about lecturing, I cannot resist giving you objectives in the classical form. So by the end of this lecture, you will be able to describe the activities in which an office of medical education might become involved, describe why it's a good idea, provide answers to frequently asked questions, and I hope if there is not an Office of Medical Education as such in your institute, you might consider looking at the possibility of starting one. So if we go to ancient history, it's my belief that if there'd been a medical school at Meroe, it would have had administrators, it would have had deans, personnel managers, purchasing agents. I'm also of the view that probably it had a parking problem and recalcitrant students as well. So who is the administration of the average medical school? And classically, we have the dean at the top. We have various vice deans, which are sometimes, but certainly not always, appropriately named. We have department chairs, and we have peasants. And it's actually a good example of a feudal system, and most of the time it actually works pretty well. So the following, I must stress, are very broad generalizations, and if they don't apply to your place of learning, then please ignore them. But let's start with the real workers, the academic staff, and take a look at the situation there. They have to teach as part of their job, and disturbingly, often, whether they do it well or badly, makes no difference whatsoever to their trajectory through the medical school. One of the reasons why I'm reasonably happy in Canada is because in my university it does make a difference. But I remember very well that academic advancement in my own university where I trained depended critically on the untimely demise of one of the more senior individuals and the consequent necessity to fill their position. In fact, in many institutions, including mine at one time or another, there was actually an advantage to teaching badly, because in self-defense the chair would remove you from the teaching roster, and that gave you more time to do clinical practice or research, which was actually rewarded. So if you taught badly, if you were cynical enough to adopt this strategy, what would happen is you would have more time to do the things which resulted in concrete rewards. Most of the academic staff have no training in teaching, and so with the best will in the world, they often teach the way that they were taught. I profoundly hope, I might add, that they don't practice medicine in that particular fashion, but certainly in many instances, in the absence of any information or guidance to the contrary, people teach the way that they were taught. And the question to be asked, perhaps, is how does a peasant become a department head? Well, usually by getting a good reputation as a scientist or clinician, and preferably a reputation that extends beyond the medical school. Usually, but not always, by not upsetting too many important people. Other routes, such as bribery or nepotism, we encounter in Canada now and again, but they are less common, I must admit. Seldom, however, by knowing a great deal about medical education. And I speak to you as an ex-chair of pharmacology, and at that particular time, when I was appointed, my interest in education had the same kind of role as those small plastic models you sometimes find in packages of cereal. It wasn't that it was an important part of things, but it was a sort of amusing and free addition. So the next question is, how does a department head reach the exalted status of dean? By being an effective administrator of a department or of a similar unit, by becoming known as someone with whom it's reasonably easy to work, and again, these are broad generalizations. Other routes, again, such as bribery or nepotism, are actually less common, and possibly it's because the exalted role of the dean, and I speak now not as a dean, always seems to me to be a little bit more the hard work than it's cracked up to be. I'm reminded of the comment of the dean at UCLA at his retirement dinner, where he made the remark that the dean is to the faculty what a lamppost is to a dog. So I think there are perhaps minimal advantages in this particular status. Regardless, in many instances, deans arrive at that exalted status without knowing a great deal about medical education. And we recently had a dean move out and a competition for deans to move into that particular position. The dean who got the job knows a great deal about medical education and has been by far the best dean that I've ever worked with. But I must add that two of the other people in the competition revealed an astounding lack, not only of medical education in general, but even of what was happening at the University of Alberta. Now, I know the situation is changing. I know we now have informed deans and chairs to an extent which a few years ago would have been unthinkable. At this conference, we have deans and chairs who have an international reputation in the field of medical education, and deans are increasingly becoming well informed, perhaps as an offshoot of some of the increased assessment approaches and licensing and accreditation approaches which are now being used. But I still think it's true that most chairs and most staff do not know a great deal about helping students to learn. Most of our colleagues are naive. It's not actually seen as being part of their job to understand medical education. There's a feeling that they were taught in a particular fashion and they turned out really well. And surely, if they've been medical students and received teaching, they will know how to do it. And I get that comment quite a lot. And I point out that if you're a passenger in an automobile, it does not necessarily qualify you to drive that automobile. And if they do become involved in medical education, is there any reward for it, or is it just more work? And finally, you're supposed to know how to do it well if you're a professor by some curious process of osmosis which has never been made clear to me. So if we have a medical school in which both the administration and the real workers don't know much about medical education, it becomes difficult to educate effectively. What we need is a source, a resource, if you like, in education. That is, we need an office of medical education. This isn't the same as the undergraduate or postgraduate medical education office. Sometimes it's under the same roof, but my own personal bias is that they do better when they're at arm's length. The administration of the faculty, as it's currently constituted, tends to look at admission, registration, courses. They look at the running of the medical school. They often have a quality control role on them, thrust upon them, for the sort of reasons that Dr. Grant talked about extensively yesterday. But if they only have a limited knowledge of education in terms of the kind of things that we heard in those first two excellent presentations this morning, they're not always going to make very good decisions. Now, if we go to recent history, this became apparent in a variety of different sites, and it's possible that Dr. Harden can identify for me the first ever identifiable medical education unit. But certainly the first North American offices occurred about simultaneously at Case Western Reserve in Detroit, the Medical College of Virginia, and the University of Illinois. And they were primarily interested in the first instance actually in educational research. It's my perspective, and it's very difficult to get these kind of data, but I believe about a third of the medical schools worldwide have such an office of education, and the number is increasing. It may be a center, an office, a division, a department, a service, and it may be medical education or health education or educational development, as it is here, or teaching or learning. But the basic role of the office is to handle the areas of teaching and learning where some expertise is required. And there are a variety of people in the office. There may be PhD educators. Increasingly, we're finding that this is very helpful. We have PhDs in related areas, such as psychology, who can make a very important contribution. Sometimes we have MD clinicians. My associate director, who's a critical part of the team, is a rheumatologist. We sometimes have PhD basic scientists. I'm one, tends to be regarded a little bit as a curiosity, but I'm not entirely alone in that. I think regardless, if you find yourself in the position of looking at an office position, there's a very steep learning curve, whether it's in medicine or education. When I became director of the office in Alberta, I found that for 5 years, I really didn't understand most of what people were talking to me about. I developed enormous skills in nodding wisely and trying desperately to look intelligent, and I'm still on that steep part of the learning curve, to be very honest with you. Clinicians and scientists have more credibility with the faculty, but they often know less about education. Educators know a lot about education, but don't always have any kind of medical or scientific knowledge in the medical school sense. And so both groups have got an awful lot to learn. I do believe, however, that it's axiomatic that those in office must be effective teachers, or all credibility will be lost. I'm always horrified when I go to discussions of medical education and somebody is purporting to present medical education in a fashion which violates all the principles which they themselves espouse. Well, what can such an office do? There are a whole variety of different things. They can do research in medical education, they can do faculty development, curriculum development, examination, evaluation of teaching, and a whole mess of other things. And culture, they make a difference to that, about an area I'm going to discuss in a moment. Starting off with research in medical education, it's really quite helpful to have a center in which this activity can be focused. I have to tell you that it's my belief that most academic staff, and remember, you're a very highly selected group at this particular conference, most staff don't even know that research in medical education exists, at which point any opinion is as good as any other opinion. And if they